Okay, if you're ready, can I start the timer?
Yes, ma'am.
Yes. So, what happened? Why am I getting this view? Yes, now. Okay, I've started the timer and here is your question. Right, if you have read and understood, let's begin our station.
Yes,
Can you please help me and identify these bones in picture A? If you can tell me,
yes.
yes, which bone is it?
So, picture A shows the scapula A and B, the dorsal and the ventral surface,
Yes. And C shows what?
the entire, upper limb connected to that.
Formation of, yes, upper limb, shoulder joint, and then, okay. If you can tell me in picture A, what is 2, please?
That's the acromion process, ma'am.
Okay, please. Can you tell me what is 15?
Supraspinous fossa,
Yes. And if you can please tell me what is 5?
infraspinous fossa of the dorsal scapula,
Okay, and if you can, on picture B, can tell me what is 11?
the subscapular fossa, subscapular
Yes.
surface.
Okay. Or foci, it says Macmillan. Okay, can you please tell me the surface marking of coracoid process? If you are asked to mark on a human being, how would you do it?
Not sure about that now. I'll come back to that question. Coracoid process.
Okay, can you please tell me how the shoulder girdle is stabilized?
Basically by the
Or what
rotator
is,
cuff
yeah.
muscles, which is basically formed by the supraspinatus, infraspinatus,
Yes.
subscapular muscle,
Yes.
anteriorly and teres minor. So these
Okay, can you?
muscles basically originate
Yes.
from the scapula and are inserted into the greater and the lesser tubercle in the head of the humerus. So they
Okay,
stabilize
can you
the
please tell
shoulder
me
joint.
what? Yes, what weakens the shoulder joint,
So there are
or
various
what destabilizes it? Yes.
the the destability is basically because of the giant or the larger surface of the head of the humerus as compared to the shoulder capsule, so the glenoid radium, which forms the articular surface.
Yes.
Then
Yes.
lack of support in the inferior surface of the rotator cuff muscles. Um,
Yes.
then
Yes.
uh,
Okay, can you please tell me what are the reflexes of upper limb that you are aware of?
ma'am, biceps reflex, reflex, and then the triceps
Yes,
reflex.
tell me the root value and how, where is it located and how do you test it?
So basically, biceps reflex we
Please.
check by tapping on the tendon of the biceps muscle, which is located by palpating on the cubital fossa,
Yes.
lateral to the brachial
Yes. And root value C56.
356, basically
Yes.
muscular nerve,
Yes.
which supports the biceps muscle. Then the triceps
Very
reflex is
good. And
basically by tapping on the
yes.
triceps tendon, which inserts just proximal to the olecranon process in the ulna, by asking the patient to hold it in
How do you place the forearm? Yes.
so
How do you
in a
place the
semi-flex
forearm?
position, passive semi-flex flex position, and extending
Yes.
the triceps tendon and tapping on the
Yes.
triceps just prior to the insertion. The reflex is
Yes.
basically to look for a sudden jerk contraction of the triceps muscle.
Yes.
Root value
And
will be
it's the root value is
the radial nerve, which
C7.
C7.
Yes.
Sorry.
What about the spinator reflex? How do you
Um,
test that?
Spinator reflex. I'm not really sure about the root value, but basically, percussive tendon. We first place a finger over the lateral aspect of the ulna and percuss over that. Um,
Okay, and the root value is C6. Okay, can you please tell me the ligaments which are attached to the coracoid process?
So the coracoid process, there are three ligaments and three muscles. One is the
Very good.
coracoclavicular ligaments are
Yes,
coracoclavicular, acromial, and
yes,
coracohumeral.
yes,
The muscles, the pectoralis minor muscle, the short head of short head of
biceps.
bicep, and
Yes, biceps
brachialis
and
muscle.
crocobranchialis. Okay, very good. Can you tell me the structures which are attached to? You have just told me those.
So
Okay.
that,
Can you please tell me what do you understand by the term quadrangular space? How is it bounded, and what are the contents of it?
Basically, there are three spaces within the shoulder
Yes,
girdle. So the quadrangular space formed by the superior most and the lateral edges. It's basically inferiorly it's bounded by the teres minor, superiorly by the shoulder joint, and laterally by the humerus,
yes,
and medially by the long head of triceps. The
Ca-
contents are basically, sorry, ma'am.
yes, yes,
The
please.
contents are basically the posterior, the axillary nerve
Axillary nerve.
and
Yes,
posterior circumflex humeral vessel.
very
Uh,
good.
and the
Okay.
triangular spaces, there are medial and
Yes,
lateral. The lateral triangular
yes,
space basically formed by the bounded medially by the long head of triceps, laterally by the body of the humerus, and superiorly by the teres major muscle, which the content is basically radial nerve and the profunda brachii vessel, and the medial triangular space is bounded, supramedially and infralaterally by the teres major and teres minor, and laterally by the long head of triceps. The content is
yes.
basically infrascapular nerve and artery. Oh,
Good.
sorry,
Thank
circumflex.
you. Can you please tell me what, yes, what are the, how the shoulder joint abduction occurs?
Abduction initiation is by the supraspinatus muscle, which initiates at
Yes,
0 to 15 degrees. Um,
yes,
0 to 90, followed by 15 degree to 90 degrees formed by the deltoid muscle.
yes.
And over 90 degrees basically by the trapezius muscle
Okay.
and uh,
Can you please tell me the origin and insertion of teres minor muscle and its nerve supply?
teres minor is formed from the the lateral edge of the scapula and inserted onto the greater tubercle,
Tuberosity. Yes, very good.
tuberosity of humerus. The
And
nerve supply
supplied by?
infrascapular nerve.
Very good.
Yeah,
No, axillary nerve. Sorry,
axillary.
axillary
Sorry.
nerve. Can you please tell me what are you looking at and identify structures 1 to 10, please?
So this is an MRI image of the shoulder joint, um,
Yes.
which shows.
If you can first identify the structures from 1 to 10 and then tell me what does it show.
uh,
What is 1, please?
the chromium process. No?
Yes.
One is
2?
acromion process that
Yes,
makes four
acromion.
correct. So two. Uh,
You have just told me the contents of this triangle, so this is one of
was
them. Axillary nerve.
lower cap. So this is the axillary. Okay. I'm not able.
Axillary nerve and circumflexion vessels. 3,
So three
please.
shoulder joint cavity or six is that?
Shoulder joint, yeah, axillary recess, it says. Okay, 4, please.
Four would be the coracoid process now.
Clavicle.
Oh, clavicle. Oh,
Clavicle.
sorry.
This is acromion, this is clavicle. Okay.
Sorry.
Right, well has gone, but we'll continue
That's
because we were
fine.
going very slow. Okay, 5
Yeah.
is, please.
Five is deltoid muscle, man.
Very good. 6 is, please.
The shoulder joint glenoid cavity.
Glenoid cavity, yes. 7, please.
7. It's a bursa.
Something you told me,
Bursa.
that thick thing you told me in the stabilizes the shoulder joint. Labrum.
Oh, glenoid labrum. Okay, yeah, yeah.
Glenoid labrum. Yes. Yes.
Yes, yeah.
8, please.
8 is the head of the humerus.
Yes. 9, please.
And 9, I'm not sure. Is it subclavius muscle or is it
It's a muscle. Okay.
okay?
Supraspinatus muscle. And 10,
Supraspinal.
please. What is this muscle?
Um,
Yes.
10 would be
Tendon.
supraspinatus
This
muscle, I
is
think.
supraspinatus
10,
tendon.
yeah.
And this is
Oh, 10 is
muscle, and
muscle.
this is 10 is tendon.
Right. Okay, ma'am.
Yes.
Yeah.
All right. Okay. And then there was this important thing which was again and again mentioned. All right. Can you tell me how the shoulder joint is formed?
So I already told that, ma'am. With the rotator cuff muscles forming uh, the stabilizing the
No,
shoulder.
shoulder
That's
joint. With no, no,
um,
no. There is stabilization, but the joint itself,
joint
it
itself is formed by
articulates with what? What articulates with what?
the head of the
Here you
humerus
can look
articulates with
and you can
the
tell.
glenoid surface of the glenoid cavity, which is formed by the scapula. Shoulder joint, yeah,
Okay. Yeah,
is
shoulder
headed.
joint. What type of joint is shoulder joint?
Ball? No, not sure.
Yeah,
Ball and socket?
synovial, ball and socket. Yes.
Yeah, okay.
All right. In case of acromioclavicular joint, if you can tell me if they have any articular disc. If yes, it is
Uh,
is it what it is made up of?
articulate. I'm not sure about the answer, ma'am,
Yes,
for
it
that.
is. Yes,
Uh,
they have. Okay, highly incorrect.
oh, sorry,
Okay,
yes, this is a question. Yes, yeah.
pectoral race major. Okay, those were with the girdle. Okay, not with the shoulder joint. What more can I ask you?
Um, I don't know, ma'am. I think the brachial plexus and everything comes in this section as well
Oh,
as.
yeah, that comes with the separate. Yeah, but would you want me to check you with that as well?
Yeah, sure, ma'am. So basically, brachial plexus is formed by the C5 to C8 and T1 roots.
Yes.
So there are mainly four stages to the formation of the plexus. That is roots, trunks, division, and cords, and then terminal branches. So the surface anatomy would be roots would be located in between the scalenus anterior and the medius muscle.
Yes.
The trunk
Can you tell me the branches which arise from the roots?
from the roots there will be a branch to subclavius muscle, a
Yes.
nerve to the nerve root to the phrenic nerve from the C5, and then C5, 6, and 7 forming the long thoracic nerve of Bell. Um,
Yes.
yeah, these are
Which
the
supplies which muscle?
serratus anterior,
Okay. When there is injury of the serratus anterior, how
winging and
does the
scapula,
patient present?
winging and
Okay,
scapula.
very good.
Right,
Very good.
and
If
then
you
from
can
the trunk,
also tell me the origin and insertion of serratus anterior, please.
the lateral surface of the ribs 1 to 9, and insertion into that's the origin, and the insertion would be onto the subscapular fossa, the medial
Medial
aspect,
border of
medial
yes,
border of
scapula. Okay.
subscapular
Very
fossa
good. Very
on the
good.
on the
Very good.
ventral surface of the scapula. So
Yes.
that's the roots, and then there is in trunk. There are two branches. That one branch would be towards the suprascapular nerve and nerve to subclavius muscle, and then there is no branches in the divisions and cords. They basically form three cords: lateral, posterior, and medial cords. Out of which the lateral cords gives
Why
the
are
lateral.
can
Sorry,
you
yes.
tell me the significance? Why are these chords called named like this?
Axillary. Sorry, subclavian. Sorry, axillary artery. Axillary artery. Sorry.
Yes, what
Sorry,
happens?
axillary
Right?
artery. So one cord would be lateral to it, and one is medial to it. Another
Yes.
one is posterior to it. So the
Yes.
lateral one gives
So
three.
with relation to the vessel, they are named afterwards. Okay, can you tell me about the injuries of the brachial plexus?
The
What types of injuries are you aware of, and
main
what is the mechanism of those injuries?
main two injuries that I'm aware of is Erb's palsy and Klumsky's paralysis.
Yes, yes.
Palsy is basically
What
a
is
damage to Erb's
yes,
point, which is formed by C5 joining of C5 and C6 at the junction where
yes,
there is branches from the trunk section as well. The patient presents with the upper limb uh, held by the side in arm paralysis of the
yes,
arm abductors, and then there will be paralysis of the external rotators because the patient
yes.
will be rotated.
And arm will be in internal rotation format,
Yeah,
and there will be paralysis of forearm,
flexors.
flexors, and spinators.
Yeah, yeah. Uh,
Yes. What
uh,
sensory loss is noticed in Erb's paralysis?
um, radial side of the arm.
Arm
Um,
and forearm. Very good, very good. Okay, compared to that, in Klumpig's paralysis, how would the sensory loss be?
so there'll be loss of the ulnar surface of the ulnar border of the arm and
Very
foot
good,
because there's
very
loss
good. Okay.
of
What is the characteristic feature or the motor presentation of Klumpig's paralysis?
claw hand, ulnar claw hand.
Very good, very good. There'll be hyperextension of
Tension
metacarpophalangeal
of
joints,
metacarpal
especially,
joint
and
and the
flexion of
flexion of the
PIP. Yes,
sector.
very good,
Yeah.
very good. Okay, right.
What
What
is the
more?
surface marking question that you asked? I don't know what was it.
Surface marking. Yes,
Of
right. We'll do that.
surface marking of coracoid process you asked.
Yes, it's
Uh,
normally almost us. It's medial 3/4 and lateral 1/4 of the clavicle. Okay, and
okay.
1 centimeter below that joint. So
Okay.
coracoid process is located at the medial 3/4 and lateral 1/3 of the clavicle, and
Okay.
1 centimeter below this joint. So that's the location. And like now, you're lucky there. It's COVID and there'll be no patients. But like before that, they used to give you pen and they used to have someone there, actor, and they used to ask you to mark the surface marking on the patient. So
Okay.
now they will only ask you and you can only demonstrate it. And they also ask how the shoulder joint is formed and how because it's not the shoulder joint alone. Here there is clavicle as well on the other side, if you can see. So how clavicle, scapula, and head is the humerus, all these are
Mhm.
formulated or made. So yeah.
Okay.
Yes, but more. Yeah, so that's quite it from this topic. But then, yeah, there are more as well that we can cover, like cubital fossa, and then forearm people did separately, and then anatomical snuff box, and the hand or the flexor. Yeah, so there are 2, 3 important topics like carpal tunnel syndrome or flexor retinoplum and anatomical snuff box, and then cubital fossa, and yeah, so like this. We have done those. Very good.
Thank you.
Thank you. Good evening, Dr. Sunday and Dr. Hana and Dr. Aisha, maybe Rafiq family. I'm not sure what her real name is anyway. Yes, anyone else want to go? Good
Good
evening.
evening.
Yes. Should we?
Let me, yeah, physical
Yes.
examination.
All right. Okay. Clinical examination. So if you're ready, can I start the timer?
Okay.
Yes. Starting timer, and here is your question. Right. If you have read and understood, kindly
Yes.
begin your examination station.
So I'll wash my hands. I will
Yes.
introduce myself.
Yes.
Then I will confirm the patient's identity and age. Then I
Yes.
will tell the patient what I'm to do. I'm supposed to examine the gland in the leg, the swelling, and the
Yes.
gland in the leg. So, and I will explain the patient and I will take permission and then I will ask the patient if the patient is in pain at all. And then if the gland is not visible, I will ask the patient which part to point at the location of the gland for me. Then after that, I will tell the patient to expose the neck down to the upper part of the chest. So the patient can sit down and relax. Then I will start my examination by inspecting the neck. So from
Yes.
both sides, front side and from back to get a better view. Then I will start my investigation from the normal side, then go to the side that is swelling. So, and I'll be checking for the size of the swelling, the shape, the skin cover, either signs of scar, any
Yes.
cyanosis, any redness, any skin change in general. Then after that, palpation. So for palpation, so I'll be palpating from the back. Then I will start from the elbow side. Then I will palpate the swelling. So I will try to feel the swelling, the edge of the swelling to get the definitive border. Then I will check for the consistency of the swelling. Then I will also check whether the swelling is fixed to the overlying skin or is fixed to any underlying structure. So I can do that by just pitching the skin over it. Then I can tell the patient to clench the teeth to see whether the swelling will move with platisma. So if not, then after that, uh, I will then after the partition, then I will move to next one. I would like to do then I have patient to open their mouth. Then I will check the oral cavity. Then I will see whether the swelling. Then I ask patient to lift the tongue, bring the tongue out. Then look at the dentition and also lift the tongue to check for any maybe any excess salivation or any obvious deformity in the oral cavity, in the oral cavity. Then I will wear glove. Then I would like to perform a bimanual palpation. So, which I will wear glove and the hand I will put inside the patient's mouth. I have to wear glove with it. Then I will take permission and I will explain what I want to do for the patient. Then I will palpate bimanually using one hand to palpate from the gland from outside and the other one from inside. So I will palpate in this case the salivary gland, that is submandibular gland. So then I will palpate, I will feel for any form of deep lobe or malformation, or I'm also looking at the patient's face for any sign of pain throughout all the palpation. So I'll check for pain, so any whether I'm able to leak out saliva from the gland or not. So after doing that, then I will remove the glove. Then I will proceed. I will auscultate the gland for any kinds of goods. Then I will also perform a pass light through the gland to check whether the light can pass through the gland or not. So after doing it, then I will now palpate the cervical lymph node. So starting from the mental submandibular anterior to the cricomastoid, superior to the clavicle, inferior to clavicle, then posterior to the cricomastoid down to periauricular and the exterior occipital region. So and up down to the knuckle line. So after checking for the lymph node, then I will thank the patient. Then I can also refer to case of the patient if patient needs help. Then I would like to complete my examination by performing general or cervical examine all the glands in the neck in general, including the thyroid, and also, yeah. So then after that, I will summarize my case. So in this
Did you
case,
auscultate it to hear the bruit?
yes, I did. So today
Okay, so yes.
examine the swelling of the 32-year-old female,
Yes.
so which is just below the right jaw. So for 2 months, so on inspection, I can see the swelling of about over in shape of about 3 by 4 centimeter. So which is obvious on the right side. Then there's no obvious intravenous cardiac sinuses. Then on the palpation, the consistency is dull, it's unregulated, and it might be slightly painful on palpation. Then bimanual palpation shows that there is, I could not make out the saliva from the right side. So compared to the left, then there's no boot on auscultation, and then I could not pass light straight. So then, based on my findings, so my mode dependent diagnosis will be swelling of this right submandibular gland due to stone. That's it. Sialolitosis. So I would
Yes,
like to also
silolithiasis. Yes. So
I would like to explore other causes
yes.
like maybe tumor of the submandibular gland, possible cancer, so which and
Yeah,
if possible,
neoplasm.
lymph node swelling like a lymphoma that could also present in that region.
Yes. So
So,
what investigations would you do to confirm your diagnosis?
investigation of choice after, of course, that's based on proper history for this patient, then baseline blood analysis to exclude the infective causes because infective causes part of my differential also. So that's infection. Then after that, I have to do scialogram. So scialogram helps to
Yes.
really diagnose the obstruction of the duct. So we'll be discussing.
Yes.
Then also this can also help as part of the medical treatment because you can also use scialogram to flush out the stone that's obstructing the duct. Then you can also
Yes.
do
Okay. What should be the treatment?
so for treatment. So we can start by conservative methods. So
Yes.
if patient is having pain medication, then also we can use a scialogram to flush out the stone if it's possible. Then if conservative method fails, then we can proceed to surgery, whereby we can make out the stone or remove the stone, just open.
Yes, you can do with silogram or cylindroscopy, or if all this fails, then you can do submandibular gland excision.
Yes.
Do you think submandibular glands biopsy would be of any benefit to the patient or for
So
the purpose of diagnosis?
if I suspect
FNAC?
any malignant
Yes.
then we can do biopsy with FNAC. So, but based on the scenario I simulated, if I have sign of obstruction, then
But do you think would that be any conclusive? FNAC can be conclusive or cannot be
by
conclusive?
it can be inconclusive. It depends. The chance, so it may not give
Yes.
any obvious information regarding this case. But if
Yes.
I maybe while palpating the lymph node that there's any regional lymph node that is swollen, especially
Yes.
submandibular fluid, then there might be need for FNAC and further investigation to rule out cancer or any
Yes.
perspective. So,
Yes. When would you ask the patient to follow up? Because we still have 3 seconds. So
follow up. So a patient can follow up after 6 months.
yes.
I'm not sure of
Thank
that.
you. Yes. Anyone else want to add on it about the follow up? Yes.
So the thing is, if I suspect cancer, so we can do biopsy, and the biopsy and treatment will be
Yes.
surgical submandibular gland. So with or without nuclear dissection. So that will depend whether there is a any enlarged regional lymph node of the
Yeah,
neck.
and then definitely if when report will come back, you'll discuss it in MDT.
Yes,
And this after discussing in MDT, you'll plan the management accordingly. Because if
yes,
it's cancer, you have to intervene further as well. You can't just
yes.
leave it without making sure that it hasn't spread locally or anywhere else. So yes, anyone else want to say something? One person wants to join, but he can't join. I'm still waiting. If he joins, then I'll say goodbye because otherwise it's not fair. Yes, anyone else?
Yeah, I missed one thing during palpation. I did not talk about the fluctuation stakes. So I think I just refer now.
Dr. Sunday, did you check for yes the nerves?
Oh no, I'm supposed. Yeah. So I've also
Yes, hypoglossal nerve and the yes, yes, marginal branch. You
yeah,
should have
marginal
checked.
planner.
How if we
Yeah.
can just go back to it? Can you
So
please complete?
for marginal mandibular nerve flow, I will ask patient to
Yes,
smile. So to smile, so that if it's
yes,
affected on the side, that means I can see dropping of the angle of the mouth on the
yes,
affected side, to that side. So
yes,
then for the hypoglossal nerve, so I'll ask patient to protrude the tongue. Of course, I did that, but I did not talk about in that
yeah,
reference. So patient protrude the tongue, so the tongue will definitely to the affected side. So and the patient cannot even
yes,
maintain. I ask patient to put the tongue inside from inside the mouth so that I can press against resistance. So that will be for apoglossal nerve on each side.
and also there was okay these two nerves, and then you did do the contralateral examination at like all the examination on both sides, because on one side is this one is on the right side, so you have
Right.
to
Yeah.
make sure on
I
the
will
other
only
side
start
as well.
from the leg. Yes.
Yes. And did you do the bimanual palpation of the gland and Watson
Yes.
duct?
Yes.
Okay. Did you do the transillumination test
Yes. At the end.
by asking by because there'll be no maybe no patient, so by
Asking, yeah,
asking
I said I will
the
pass light.
examiner to dim the light? Yes,
That I will pass light through the gland, so by checking from the other side. So sometimes I can roll the paper, then look through
yes.
the paper, see whether I can see the light passing through the cell.
And did you check the tongue by with the cotton wool by asking the patient to close the eye, and every time you touch, patient will tell you if you have touched or not.
So sensation, that to check
Sensation,
migraine,
yes,
no, but I
of the
do check
lung.
the tongue. No, I did not do that.
Yes, and then there was pulsatility and consistency, temperature, tenderness, all these things. I'm sure you have done those. Right. Is there anything else one should do to complete the examination?
So that would be to examine all the glands in the neck
Cervical
and
lymph nodes, especially.
and also the organ node. Yeah.
Yeah. So that is also important. Okay. What is more important about this? That you palpate thyroid, submandibular, you're already doing parotid, and cervical lymph nodes. Like
But,
these all you have to do, or at least say that I'll do these examination to complete my examination. Right. What if a patient's lump is not visible? What
Yeah,
would
so
you
I want
do?
to point, point to the swelling, so that I will know which side is swelling, so that I can only start from the
Yes. A-
normal side.
Yes, and did you ask the patient to prepare or after giving consent to expose the
Yes,
area?
yes,
Yes.
yes,
Okay,
yes.
what should be the position of the patient when you're doing your examination?
Sitting, sitting.
Sitting, yes. And at least a patient should have exposed the neck, so unbutton the at least
Yes.
shirt or blouse or whatever patient is wearing.
Oh, I put the neck to the below the collarbone.
Yes,
That's the
yes,
clavicle.
that is what recommended. Yes, good. So right, that person has failed to join, but then we have discussed our station pretty well. Thank you.